Hello everyone, and welcome to CK Med. My name is Clark, and I'm going to be walking you through pelvis and perineum anatomy today. To start things off, we want to get to our bare bones, backbones, and our perineum, and so let's discuss what those bones are. And so some things that you want to be able to identify are the main four bonus structures found within your pelvis. And we'll talk about our true and false pelvis in just a second. And so those bones are our ilium, which is right here. The ilium is a very large, flat-winged bone and pretty much creates your hips, which are found right up here, and that's where you should be putting your pants, not sagging them down low. And at the anterior portion of our ilium is we have this anterior superior iliac spine, also called your ASIS. On the back side, we have this spine back here, and this is your PSIS, your posterior superior iliac spine. And these are very important for attachment parts of our muscles in our legs, such as our sartorius muscle, and that's also with our quadratus femoris muscle attaches here, and this allows for flexion of the hip, or lifting up your or kneeing someone in the face if you're in wrestling, okay? And so that is your ilium. Now we have two other bones which kind of crack down right here. So crack right here, and this is the dividing point between our ilium. And this is our bone right here is known as anyone know what this is? This is our pubis bone, or pubic bone. And this will create this section and hook it together to the other side, and this is known as your pubic symphysis. And then our lower bone, which is our butt bone, and just like I have no muscle around this bone, and so I'm very bony butt, and this is our ischium. And in our ischium is a very important structure, which is found right here, is our spine of our ischium. And this narrow location, which is emphasized by this red arrow right in the middle, is our interspinous space. Now, in males, who cares about that? But in women, this is very important because it is the narrowest part of the female pelvis that allows for a baby's head to be able to squeeze through this area. And if this area is too small for the large baby she might have, then a C-section must be performed. And then lastly, obviously, as we're talked in our back and spinal nerves video, this is our sacrum that runs along here, and we have these joints that run between each of those. So this is kind of the bare bones of our bones for our pelvis, but let's talk about our true pelvis. And so if I were to draw kind of a circle that runs around here, this is my false pelvis. And so this is, we always think, oh, well, everything below your hip bones all the way down into the pelvis is your pelvis, but it's not. This is actually false pelvis, where true pelvis is actually around the pelvic brim, which is this area right here, pelvic brim, the pubis at the anterior portion, and the sacrum in the posterior portion. That is actually true pelvis. And what kind of separates them two is in our false pelvis, we have muscles that are attached in here and all this stuff. It's not really our pelvic organs. And our true pelvis is where all our organs are. Our bladder, if you're a woman, as in this picture here, you also have your uterus right here, and then rectum and stuff like that. And then some of the underlying structures like our ureters that come in, and our ovaries are hanging out over here like this. All these are pelvic structures, and they are found within the true pelvis, and they're held up from the muscles that run under here, and we'll be talking about those in just a little bit. Now, how do I differentiate a pelvis between a man and a woman? Now, usually it's quite distinguishable as far as the true pelvis shape, where a female pelvis is more kind of heart-shaped, where males is more of a kind of oval-shaped, but that's not a really good way. Actually, a great way is the angle that our ischium and our pubic bone kind of make. And so when we have a 90-degree or less, kind of an acute angle, like this over here, that is what a male has, where a female actually has quite a wide one, quite a wide angle, 100 degrees or more, and this is kind of showing that women are able to have a nice open birthing canal for baby, where men are unable to do that. All right, so now let's jump into this person's abdomen and then face to the front as if it's like a little equipment bodysuit or something like that, and then we look down where our feet are standing on. And this is the view. This is sort of the bird's eye view of the pelvis. So here's our pubic symphysis up here on the top. This is our sacrum back here. And so what can I see? Well, I see the rectum that's running along down here, and then I see we cut the uterus in half. We have these vessels that are running right here and a vessel's running right here into the uterus. So I'm guessing that is my uterine artery. Oh. Okay. And the uterine artery is found within a ligament that's holding it up. And this is a very, very strong ligament that keeps the uterus up. And we'll be talking about that later when something goes wrong with that ligament. But this is known as your cardinal ligament or transverse ligament. And this comes from over here on the side. From your ilium, /pubic bone meeting point, the pelvic brim attaches over here to your uterus and keeps it up. So it doesn't kind of sink down and kind of slip out of the person's pelvis, which would be bad. That'd be called prolapse. And then we also have this structure, this white structure that goes into the bladder, and this is our ureter. And so you can see that ureter carrying water is going under this ligament. So the ligament is actually on top. And so this is something we call water under the bridge, water under bridge. And so what they mean by that is a ureter carrying water is running under the cardinal ligament of the uterine artery, which is the bridge. And that then goes into this structure, which is very muscular and round, towards your pubic area. So if you've ever had a UTI and a doctor reaches over your pubic bone and pushes on something and it's like, ow, that is your bladder. And so if someone comes in, like an OBGYN coming in to do hysterectomies, then what do we need to do? Well, we obviously need to ligate or block off the blood supply so that when I cut out this organ, it doesn't just bleed like a hose. We need to kind of squeeze off that artery so that stops. And then we can cut out this by cutting the ligaments that are attaching and holding it up. Then we can cut out the uterus, and you've successfully completed a hysterectomy or removal of the uterus. So now another question that could come up is, since we were looking, if we go back to this area here, if I were to pour water in this bowl of all these different organs and stuff, where would you see water going? Well, it looks like this area actually right here looks like that is actually the deepest area. So if I poured water, it would kind of run down like a little waterfall into this area, which is between the uterus and the rectum. And this is called your recto-uterine pouch, or pouch of Douglas. And so this makes sense that if I were to pour water, what is the place you're going to find it is this recto-uterine pouch. How do I get that out? What if this fills with fluid over here in this recto-uterine pouch? Well, I stick a needle right through here, through the posterior fornix, and suck that out. That can be done through colposcopy. Colposcopy is a visualization, but we insert a needle through the posterior fornix of the cervix, which is right here, this area right here. This is the anterior fornix, posterior fornix, and that will allow us to stick that needle and suck that fluid in the pelvic area out. And this occurs, so if I have a female, a 35-year-old female comes in, has mild abdominal pain, and we notice that there's fluid in the abdomen. Well, when this person, a female, sits up and stands up, then where is the fluid going to collect? Please remember the recto-uterine pouch of Douglas is the name of this. And a male, well, we don't have a uterus, so it's not possible for us to call it the recto-uterine pouch. Instead, this is actually more of a rectovesicular. Why? Is because you have the rectum right here, and then we have a pouch in between this and this sac of water, also called a vesicle / bladder vesicle. That's just another name that we call the bladder when we're referring to medical terminology. So rectovesicular pouch is the place that this fluid is going to collect in a male, where the recto-uterine, because the uterus, remember, is in between the bladder and the rectum, is going to be the place called pouch of Douglas, where the fluid is going to collect. All right, so now some more pouches, and these ones are a little bit more detailed and kind of important for some questions to come up. And so our perennial pouches, these ones are actually really annoying because it doesn't quite make sense when you look at pictures very much. So let me switch back over to essentials anatomy, and you can see this more on a three-dimensional view before we come back to talk about these structures here. So here we are with our essentials anatomy, and we're going to be looking at the pelvis today in a 3D view. And so again, we have our ilium up here, large bone up to the top right here. We have our pubic bone that runs down here, and then our ischium is our butt bone that we sit on. And then we have all these different muscles that run and attach within this area. And so let's go ahead and identify some of those now so we don't have to really look at them much when we get to some of the pictures. And so one that's really important is known as your iliacus. This binds to your ilium and goes down into your leg, allowing for an internal rotation and for a flexion. This combines with your psoas muscle, which is going to be running right here from attaching on your lumbar spine, running along, and it creates your iliopsoas muscle. Just a combine of those two muscles together. Within our true pelvis, let's go ahead and look in our true pelvis, which is defined as, again, our pelvic brim, our pubic bone, and our sacrum. In the posterior aspect, this is where all the organs are going to be found. And some of the muscles that are very important, your piriformis is a pear-shaped organ that kind of takes up this area back here. And so actually, if I were to remove this over here, what is this space? And this is actually your greater sciatic foramen. So greater sciatic foramen is where your sciatic nerve is going to go through. This is our lesser one. Greater on top, lesser on the bottom. Greater sciatic foramen on top. And things that run through the greater sciatic foramen and then come back in the lesser one is going to be a very specific nerve you should be able to identify, and that is your pudendal nerve. Also, your pudendal artery is going to be flowing through there as well, or internal pudendal. And so these nerves and vessels come from the true pelvis. They go out of the true pelvis and then come back in to sneak into a little pouch that's under the true pelvis. So if I were to put the nerve in over on this side, you can see this is the wall of the true pelvis. I'm now outside of the wall. This is the muscle wall. They would be on top of here. The nerve and artery would be outside of the wall, like on this side. And so what happens is they actually sneak into what is known as your perennial pouch, or your deep perennial pouch. They go out of the true and they come into the deep perennial pouch, which is right down here. So you can see this kind of space around. This is the anus right here, and then the urethra for male is going to come out this way, but this is kind of an area that has a little bit of space in between. We have our connective tissue down here. We have some muscles of our butt that run down this way as well. I've removed those. But we have this kind of small space that is around and surrounding your anal rectum area, but outside of your pelvis. So this is the floor of your pelvis, the levator ani muscles, but now we've removed that, and you can see that this nerve and artery kind of come in here. So our internal pudendal nerve actually becomes our perennial pouch, our perennial branches in this area. I know it's labeled differently here, but once it slips into the deep perennial pouches, it becomes your perennial nerve. And you might go, Clark, what is that for? Well, your pudendal nerve is a somatic motor nerve and a somatic sensory nerve. And so if I have in the perennial area, if someone stabs me in the perennial area and ow, that's that pain, it's pudendal, somatic. I'm going to point exactly where that person stabbed me. It's not going to be a generalized area of pain. It's going to be right where that person stabbed me. But also what else does it do as far as motor is it allows you to control this muscle, which is your external anal sphincter. So as a child, this is something you train that you get trained to be able to use and to be able to hold in your poop and your urine as well, because you also have external urethral sphincter that's also controlled from your pudendal nerve. So this is very important to know that your pudendal nerve goes out through the greater sciatic foramen, in through the lesser sciatic foramen, becomes your perennial nerve, or internal pudendal perennial nerve, and then innervates your external sphincters, your kind of voluntary sphincters of both your urethra and your anal canal. And this is within your deep perennial pouch. And if I were to say, how do I find that nerve? Well, look at this. Okay, So I'm looking from the front side. I have my anal canal, and I have this nerve on this side. So this space down here, let me do a little drawing. This little space down here, it's kind of like a little triangle that this slips through. So if I were to do a CAT scan, I would see a triangle. This is on the lateral portions. This is called your inferior pudendal canal. Also is called a surrounding or circumferential anal fascial area. So this is an area that has the pudendal nerve found within it, and so this is how I can find that. Is I find the anal canal, and lateral to that I have this area where it has a bunch of fat in it, and the nerve is running right through it on the lateral wall. And so that is where I can find my pudendal nerve in the perineum. Okay. So I hope this makes sense, is that I come from the true pelvis, I go out and come back into the deep perineal pouch, which is down under here, under the pelvis. And so this is kind of important. And then once I get out of the deep pelvis, out from in here, and actually come out under kind of the skin, this is my superficial perineal pouch. So superficial would be down here when I have skin kind of sagging right here. I know I can't put the skin in here, but I can have skin sagging in here, and I have a pouch in here. If this were filled with blood, that would be my superficial pouch. If it were filled in here, I'd have my deep perineal pouch. So back to our perineal pouches as far as what we're looking at in here in these pictures. So please remember that your deep perineal pouch is things that have some of the muscles found within there, like your deep transverse perineal. That kind of just houses some of the wall of your deep perineal pouch. Don't worry about that too much. But the blood vessels, your pudendal blood vessels, and your pudendal nerve are found within there. And then your urethral sphincter and your anal sphincter, external for each of those, are going to be found within that. And then one important structure found right here, which is your membranous urethra in men, is a place of rupture. And rupture could be occurring due to car accidents or something like that, where they can actually rupture this membranous urethra because it's quite weak, and that would bleed into, well, where it's found, deep perineal pouch. And how I can determine this is I do a Dr. Dre or DRE, digital rectal exam, stick my finger up their rectum, and like I would feeling for their prostate, and I feel that their prostate is actually risen. So I'll show you that in just a little bit as well. And then lastly, we also have our bulbourethral glands, but that's not super important. Our superficial pouch is pretty much our area of skin that's kind of holding in some of these things kind of below this. So here's my superficial pouch. Again, this is my prostate right here. And then this area in that pouch where the nerve was running through, that's my deep perineal pouch. And then more superficial on the outside, which is like my skin here, this is my superficial perineal pouch. All of these areas, both deep and superficial, are innervated by my pudendal nerve, so please remember that. Okay, so now on to some of the basics for arterial supply. Please don't take these circles into consideration as super important. They just came with the picture. I did not circle those. But I just wanted to emphasize kind of the basics you should understand. You should understand that at L4, we have a bifurcation of your aorta, making your common iliacs. Your common iliacs then break into your external and your internal iliac muscles, or arteries, and also your veins as well. And then your internal has two branches. Don't worry about which one houses what artery, because this is all kind of random. All these different arteries can come off of different branches, so that's not super important. Just knowing kind of where they're going is the most important. And I know they've told you that, and it's very frustrating, but unfortunately it's just very true. So you have to see where these vessels are going, and that's going to tell you what's happening. So if I have a blood vessel that goes out the greater sciatic foramen but stays outside of the greater sciatic foramen, that's going to be your inferior gluteal muscle, and that's going to be something for your gluteus maximus, or your big butt muscle, pretty much. If it goes in and then back, or goes out to the greater sciatic foramen, then back in the lesser sciatic foramen, this is what we emphasized over on there, which was your pudendal nerve. And as far as the remaining portions of our internal iliac, just know where they're going. So if they're going through the obturator canal, that's your obturator nerve. If it's going to your umbilicus, that's your umbilical artery, which shouldn't necessarily be there. It's just a fibrous band, like we talked about in abdominal pelvic wall video just prior to this one. And other things like arteries that go to like your bladder. So they go on top of your bladder, that's your vesicular artery. Ta-da! But then some things that are also important are your superior gluteal. So that's something like a very large vessel that pierces through your greater sciatic foramen and goes to your abductors. So your gluteus minimus and gluteus medius. And that's something clinical when you get to lower limb that comes up. But then some of these other ones, obviously, yeah, you have your lateral sacral artery, whatever. It just supplies some of these areas that aren't technically clinically relevant until you get to your surgery rotation. As far as what we talked about before in our last videos, and I did want to emphasize that here, was we have our external iliac arteries that becomes our femoral artery here in the leg. But before that, we give off this vessel called your inferior epigastrix. That's this one right here. And so your inferior epigastrix actually are something super important when we talked about the reference point for our inguinal hernias. And so please remember that this comes up and supplies the abdomen from the bottom where superior epigastrix come to meet, and the umbilicus is the meeting point. Okay, so now that we've talked about the arteries, the veins are going to be following the same structures, so let's talk about lymphatic drainage. Now, lymphatic drainage is something that's very important to understand because they could ask you, where does this go, or where are you going to find the nodes of this cancer developing from this particular organ? So if someone has bladder cancer, where does it go? And so this is actually very easy to identify because simply once you know the arteries, then you know the veins and you know the groups or the main vessels that you're going to find for your lymphatic drainage. So for example, as we talked about our ovaries and testicles developing at T10 and bringing down the blood supply to them, such as these guys, you can see the blood vessels right here. In a woman, the ovaries and the fallopian tubes and then the top of the uterus is going to be supplied from your lumbar arteries, which come off as your ovarian arteries, and your ovarian arteries supply the fallopian tubes and the fundus of the uterus, the top of this, and this will then allow the lymphatic drainage to go back to the same place, which is your lumbar nodes. Remember, ovarian artery. Both the body, or the middle portion or the lower portion of the uterus, and the cervix and the upper vagina are all coming from your uterine artery as far as blood supply. And where did the uterine artery come from? Well, that came from your internal iliac nodes. Now, you might have some off of your external, but internal iliac is the one to really remember there. Now, as far as the lower vagina, the labia majora, everything on the outside, kind of past your superficial pouch that we were just talking about, then that's on the outside, and that's going to be more on the outside nodes, which is going to be your inguinal nodes. Your outside nodes are your inguinal nodes. And since it's coming from the butt, and also, or like butt area slash reproductive outer portion of this this woman, it's going to be going horizontally to get to the inguinal. So here I have like the labia majora and everything like this. Well, how does it get to there? Well, it's got to go horizontally to get to those nodes. If it's coming from the leg, then it's got to go vertically, and that's your vertical nodes. And we'll be discussing that in lower limb. And then one special case, and this is actually the most important thing other than where does the ovaries drain, is their clitoris, and also glans, penis, and males actually go to deep inguinal nodes. So please remember, if I have a 60-year-old female that comes in with a pelvic swelling or abdominal swelling and some abdominal pain, and then we figure out that this patient has ovarian cancer, we remove the cancer and we go, oh, we better check the lymph nodes. Where are we going to go? Lumbar. Same thing for uterine cancer. If we find something like that, or cervical cancer, where does that go? Following uterine artery. Uterine artery came off of internal iliac. Please choose that. If you have something like vaginal cancer, like lower vagina, or something like skin cancer in the vagina, which is very strange as to why sun exposure is occurring there. But with that, that should be going to your horizontal superficial inguinal nodes, and then the clitoris would be a very strange place for cancer to be occurring, and so very unlikely. It would be more of just where does the clitoris drain as compared to some of the other structures. Okay, male lymphatic drainage, very similar. Testicles, again, started from T10, but now took it down into the scrotum instead of just in the lower pelvis with the ovaries. It just took a little bit further. And so the lymph drainage just has to reach further, but it still originates in the lumbar or para-aortic nodes, so it's still going to be going back up there. The scrotum and penile shaft, actual outside, is going to be your superficial inguinal nodes, as we were just talking about. That's going to be your horizontal group. Horizontal group. Again, the glans penis, same as the clitoris, is going to be deep inguinal. And then bladder and prostate. Those are all things in the lower pelvis, and so that's going to be kind of depending on which part. If it's the top part of the bladder, is going to go to your internal iliac, and then the lower part of the bladder is going to be from your pudendal supply, your pudendal arteries. And remember, that goes down to your external urethra, as well as your prostate's down in your deep perineal pouch, or just around in that area. And so your pudendal, and where was your pudendal from? Again, internal iliac. So please know that. Yes, there's all these little ones mentioned here, but please, internal iliac, that's why it's red, is the most important to remember. And this kind of just shows what we're talking about, all the blue, as far as like where it comes from. Ovaries, top fundus here. Blood supply comes from this area, so therefore the lymph nodes are going to be draining this area. Same thing, testicles went down in the scrotum, came from way up here at T10, so it's going to be draining into your lumbar nodes as well. And some of these other ones, like obviously this is just a good picture, kind of points out some of the other areas, like the glans penis and the clitoris are going to your deep inguinal, and some of these other ones. There is kind of variation on these things, like, oh, part of this goes to your external iliac, and then part of this goes over here. Like, don't worry about that too much. Just emphasize like the big things, such as the top of the uterus, like I was explaining. Guess what? How do I ask you a lymph drainage question? Well, lymph drainage questions usually are associated with cancer questions. So just think of what are the common cancer types in the pelvis of a woman and a type of a man, and now there is your question as far as lymphatic drainage in this area. So don't worry about all these, like, okay, 4 inches up of the rectum over here, where's that going? Oh, pararectal. No, not important. Sacral, not important. Deep inguinal, yes. Superficial inguinal, yes. External iliac, not really. But internal iliac, absolutely. Knowing what blood vessels came off. Same lymph drainage following that area. And then this is for abdomen. Don't worry about that too much. Common iliac, whatever. But lumbar is very important. So just know, like, what are the types of cancer? Well, testicular cancer, para-aortic. Ovarian cancer, para-aortic. Cervical cancer, well, that's kind of lower. Well, the cervix is supplied from your uterine artery, and your uterine artery comes off of internal iliac. So just use that same logic to think of how questions are going to be asked about cancer types that you know of. Bladder cancer, for example. Now, bladder cancer, just remember your bladder is supplied from your internal iliac. So please choose your internal iliac lymph nodes. I know there's like a little yellow coverage on the top of the bladder that's external iliac. Don't worry about that too much, okay? Just get the big picture. All right, so now that we talked about lymph drainage, let's talk about some of the pelvic pain. And this is like a really weird concept that is very strange, and everybody gets this kind of wrong as far as why they ask us. I have no idea, but you will never get this on a step question, or very, very, very unlikely. But as far as anatomy, you do need to know. And so what the best way to do this is to look at the organs of your pelvis. Remember that kind of bird's eye view that we had in the first picture? And I looked down, I saw the rectum, I saw the top of the uterus, and I saw the top of the bladder. And like, you know, those structures, I could see the top of them. I can't see the body of them. Like down here, I can't see the cervix, I can't see the lower part of the bladder, and I can't see the lower rectum. And those things, like I can't see the prostate, those sorts of things. But I can see the tops. So this is kind of a nice way of thinking. That is the pelvic pain line. So what is the tops? Well, we removed the tissue that was laying on top. So when I was looking down from bird's eye view, there was actually a blanket on top of those things. And that blanket is your peritoneum, which is this blue that's running right along here, right on top. Aha. So everything that this peritoneum touches, so the fundus of the uterus, the fallopian tubes, and the ovaries coming out to the side here, and the upper rectum and the sigmoid colon, and then in addition, like the top of the bladder, any of those areas, if they're experiencing pain, rupture or stabbing or something like that, if they have damage to these areas that is causing pain, then if I were to ask you what fibers, or like what nerve fibers will carry those, like the sensory pain fibers, and that is going to be sympathetics. Same thing for abdomen. In abdomen, if you have pain of organs and stuff like that, they're going to be traveling back with your sympathetic fibers, and these are known as your sacral, or not sacral, I'm sorry, your visceral afferents. Visceral afferents are your sensory fibers that are organized with your sympathetic fibers. And so T10 to L1 are the ones that are kind of covering this area, the pelvic pain line. So those are things that, again, are touching peritoneum. Top of the bladder, uterus, ovarian tubes, ovaries, and upper rectum, and sigmoid colon as well. But if you go below that, so below the pelvic pain line and above the pelvic diaphragm, so pelvic diaphragm is here. So that's just thinking of what are all the organ pieces, the lower bladder, the cervix, and the upper vagina, and then the lower rectum are all found above these muscles that are running here, which we talked about, the levator ani muscles. All these kind of organ pieces here, what's carrying these sensory? And this is actually going to be carried around with your pelvic splanchnic nerves, or your parasympathetics. Here there were sympathetic fibers, and now they're parasympathetics. Now, you might be asking this question, and it's really annoying. What's with sympathetics? I know that the sympathetic nervous system is your fight or flight, and your parasympathetics is your rest and digest. How are they carrying sensory? No, that is the real question that comes in here. So what this actually means is I have sympathetic fibers going to the organ, so sympathetic. But within this little tunnel, same tram tunnel that the nerves were coming out to do whatever sympathetic or parasympathetic caused the bladder to contract or whatever, or to relax, for sympathetics. So these fibers are going this direction, right? Sympathetic fibers are motor. However, we also have in the same tunnel fibers going backward, and that's our sensory. So visceral afferents are what those fibers are. They're still carried within the same nerve, so I'm going to draw this found within here. So I got the same nerve that's found here, same canal, got a 3D tube. But both of these fibers, sympathetics are going out to the organ, the visceral afferents are carried along with it, but backwards, going back up for sensation. Where on the other hand, parasympathetics, now we have this parasympathetic tunnel that's running down here, that's carrying parasympathetics down, but then we have our visceral afferents coming back up through those, and that's for something that's below the pelvic pain line but above. And how you can differentiate that is just do either what lays on top, that's our pelvic pain line, and then everything below but yet above the muscle is going to be your parasympathetics, and then everything below our pelvic diaphragm, which is all our muscles, is all going to be where pudendal goes. And as I was talking about, pudendal is a somatic nerve. It means when you poke at it, it tells you where it is exactly. Here is kind of generalized. I have lower pelvic pain. Where is it? Lower pelvic pain. Great. Thanks, patient. You didn't really help me with that information. So that's what our visceral afferents are going to be having. But this is somatic afferents coming with pudendal nerve, so it's going to be kind of a sharp or very localized pain, and that's pudendal. And that's going to be things like external genitalia and lower anal canal comes through there. Okay, so let's talk about some of our prostatic diseases. So things like benign prostatic hyperplasia and prostatic adenocarcinoma, which is a type of kind of mucousy secreting cancer. And so the most important thing just to know is where are they usually located. So benign prostatic hyperplasia is going to be found in our median lobe, which is down here, or also called your transurethral or paraurethral zone. And so if I have BPH, what it's going to do, this person's going to have trouble urinating or trouble initiating or starting the stream of urine. They have low flow is how they're going to be describing it. 72-year-old guy comes in. He says that he's been having trouble urinating for the past 6 months. Stream is very weak, and he's having trouble starting his urinary stream. And at that point, bam, BPH. Okay, well, how do I test for this? Well, I stick a finger up the rectum, as you've probably seen in all those movies where the doctor kind of whips on his glove and stretches it, and it snaps. And he goes, bend over. Okay, that's the DRE, digital rectal exam. So you reach into the rectum and you feel around here. So this is where you kind of put your finger here to feel the prostate. If it's enlarged and smooth, then that's most likely your BPH. If it has nodular and kind of weird hard feelings, kind of firm, then and you're actually feeling that, that means it's probably developing from your posterior lobe. And if it's abnormal, it's got nodules, that's probably your prostatic adenocarcinoma, and that usually develops from your posterior lobe. Now, the problem with prostatic cancer, usually a disease of older men, African Americans, poor diet such as greasy foods, and patients with hypertension. Those are all kind of risks for prostatic adenocarcinoma. But what happens? Usually patients actually don't die from the cancer, they die of other things. But they have severe back pain and problems with that. Sometimes it can actually go to the brain, and you might go, whoa, wow, how did prostate cancer get from way down in the perineal area to all the way up into the brain? And so how this happens is actually we have a prostatic venous plexus right here, and this prostatic venous plexus is hooked up to your vertebral venous plexus. It's called your venous plexus of Batson, vertebral venous plexus of Batson. And this is a valveless system. So when this person lays down or they do cartwheels, this blood is flowing back and up, back and up, back and up, back and up. So this is how I'm carrying my cancer all the way up, and it can go all the way up to the brain. This is my wonderful brain right here. Okay, so that's how I get prostatic cancer. Please remember, venous plexus of Batson, or vertebral venous plexus of Batson. Okay, so this, in our last video, we talked about really before, so let's quickly do this. Hydrocele versus varicocele. Open processus vaginalis kind of flows through, and it fills up this area, and you got hydrocele. I light it up, ta-da, it turns red. In a varicocele, remember we were talking about the right side actually just plugs straight into IVC. On the left, it goes into your renal vein and then goes into your IVC. And if I can have my superior mesenteric kind of squeeze this, we get our nutcracker syndrome. And nutcracker syndrome is pretty much a left varicocele, and this is what it looks like, and we call that bag of worms. And it's something that when someone, the way they can also describe this instead of bag of worms, because that's like a dead giveaway, is that this person, it swells as they stand up, but when they actually lay back down, this swelling goes back away because now the blood is up here filling up this area rather than down here in the testicle where you can see it. That's one other way that they might be able to describe that. Okay, so let's talk about some of our incontinence. So this is either fecal incontinence, where you just poop yourself, or urinary incontinence. Now, urinary incontinence has different types, and you'll learn that more in physiology and neurology than you will here. But some things as far as anatomical defects that can cause either of them is quite important. So if you have urinary incontinence versus rectal incontinence, you kind of have to understand the structure. And so let's have this female pelvis right here, and we have the vagina right up here. We have our urethra up in the front. We also have our cervix here, which is where our uterus is going to be, and kind of found like through this area right here. And then in the back is where our rectum would be. Okay, so if we're dealing with urinary incontinence, we really have to mess up this area in the front. And so the things that we can do obviously needs to be something that is not, or that's holding this tight. So through this area, I'm going to draw this on a little bit bigger scale. I have my urethra here, and we have this kind of tendons that are helping and attach and yank on this. And when this yanks on it, it allows for a stabilization, and that allows then for external urethral sphincter to close up. So this is our urethra. This allows it to close up. But for some reason, if we cut this, we cut one of these ligaments, and this is known as your arcus tendinous fascia pelvis, either that or our pubococcygeus muscle. All of these things, either the fascial tissue or the tendon, and also your muscle that's attached to this, which is here, if we cut or damage this, then this is going to be misaligned. And so now the tube more looks like this. So let me draw this again. So now we have this way over here. And this is where my external sphincter was able to squeeze. And now you can see that this urine can kind of pass right around through this. If I'm not stabilizing it, keeping it there, then it's going to kind of like snap and loosen around and not be in its place and allow for urine to kind of pass through. So one important thing to know is that tendinous arch, injury to the tendinous arch fascia pelvis is a very important thing, and that can occur during childbirth, and that can cause urinary incontinence. As far as other things that can cause this, if I damage the external urinary sphincter, obviously, that makes sense as to leaking urine. And pubococcygeus muscle we can also damage. So that is this right there, this little one that's running right here. Okay, and then we also have our fecal continence, obviously another thing that's wrapped around this arrow. So here is our anal canal found right here. This is also wrapped around there, and this is our pubococcygeus, and specifically the puborectalis is the most important one, and that can actually, again, same concept. We want to keep it tight and stabilized, but if we have it loosey-goosey on some side, we're going to have loosey-goosey fecal matter. And so your puborectalis is going to be causing it to loosey-goosey up, and that's going to be causing fecal incontinence. Other things is obviously the same as over here, external urinary sphincter or urethral sphincter. We also have the external anal sphincter, or damage to that pudendal nerve. For either of these, it can cause that incontinence as well. All right, so now some of the perennial injuries. We did talk about this. We talked about the deep, and we talked about the superficial pouches. So now let's do a little bit of clinical anatomy. So some things that you might be able to see are like penile edema, or urine found within the penis. It's stuck within just the penis by itself. You might go, oh, that's really weird. Well, this is due to a rupture of the spongy urethra. So let's see right here. So we have our bladder right here. We have our prostate right here, so the prostatic urethra. Then we have this small little space called your membranous urethra. Then this space right here is your deep perineal pouch. And then you have your spongy urethra. So spongy urethra comes out here. But if I have a rupture of this spongy urethra, but not the sac that holds and around the penis, then we're just going to fill in that sac right around the penis. And that sac is called your buccal fascia. Now, if I rupture buccal fascia, it's going to go into the bigger bag. So just think of this. I have a very large bag, and this goes up the abdominal wall up here. And then the penis, it also goes around, which is here. I'm going to draw that there. Okay. And with that, then we have, I'm going to redraw this. Okay, this is my pouch. So penis found in here, this abdominal wall. But then we also have another bag. So here's my penile bag right here. So this is buccal fascia. And then we have urethra that's running right through them. Okay, so if I just rupture the urethra, I'm going to fill in just the first bag, and it's going to fill in this place. And that is when buccal fascia is maintained. But if I also damage through the urethra and through buccal fascia, I'm going to fill in this area, and that's my superficial pouch. And so if I just have penile edema, it's rupture of spongy urethra, intact buccal fascia. If I have a butterfly ecchymosis that runs up the abdominal wall in this superficial pouch, which is all over the place, up to the abdomen, such as this guy right here, all the way up this way like this. Here's his butterfly ecchymosis. Then that is because we damaged the spongy urethra and the buccal fascia. So the urine and everything goes into the superficial perennial pouch. This is super important. So if you have someone that just decides to step into a sewer, crack his nuts on the edge, and then he has this ecchymosis. That's because he's damaged both of those things. And then lastly, one important thing which I talked about is if I damage that little piece right here, the membranous urethra, this little thing that I'm circling right up here, if I damage that, I'm going to bleed into this area, which is my deep perineal pouch. If I bleed in my deep perineal pouch, I can stick my finger in here. This is my finger. Haha! I have all my other fingers. Woohoo! Okay, if I can stick my finger, well, I shouldn't be sticking my thumb, but that's my finger, and I'm feeling for my prostate. If this cuts, my prostate's going to go upward, and this is known as a high-riding prostate, which you can see in this picture. And I'm going to be bleeding into this area that's filled with black blood right here, and that is my deep perineal pouch, and that's due to a rupture of my membranous urethra. And so that's something you won't see on the skin. You're not going to see them bleeding, but this is something you need to be checking for if you have a high-riding prostate on digital rectal exam. This is bad because you can have a lot of blood in there that can bleed out and die. So please be able to pick that up. Okay, so next is our form of impotence. Pretty much the guy can't get his thing up is what impotence means. And there's kind of 3 etiologies to this. And this is actually kind of important where really your step questions are going to be coming from. And so this is the way you kind of can put this. If I have a man that comes in, he says, oh, hey doc, I'm having trouble getting my junk up when I need it, when I'm wanting to perform with my wife. But unfortunately, I've been having some arguments with her, or I'm stressed with work, or something like that. A little bit psychological stress on him. Any arguments or anything where he's kind of worried or anxious, anxiety, whatever it is, that is a neurological problem. And the way you can kind of confirm this is you wrap a piece of tape around his penis before he goes to bed. And if that tape kind of breaks off in the middle of the night, that means he had an erection overnight. That means his penis has no problem whatsoever getting erect. And therefore, that is a psychological aspect. His libido is down because he's having anxiety or something. The other cause of this is actually when there's problems. So blood supply is either cut off. So this is someone they're going to be describing as a 57-year-old man, comes in with impotence. He has cardiovascular risk, hyperlipidemia, and he has 3 coronary stents in his heart, and also he has peripheral vascular disease. And then when we do this little nighttime test thing with the tape, the tape does not break off. At that point, that means there's a functional disability, and that's due to occlusion of the artery, and that is because of atherosclerosis. Now, and the last scenario is a nervous or neurological problem. So part of erection is where we're going to be talking about this, and this comes down to your parasympathetics and sympathetics. This is your point and shoot. So P and S. P for point and parasympathetics, and shoot for sympathetics. And the way or what nerve roots these come from is from your sacral splanchnics for S, so sacral splanchnics. Okay, and your pelvic splanchnics. Okay, the easiest way to remember this is your pelvic splanchnics are your S2, 3, 4. These are your sacral splanchnics, S2, 3, 4. But remember, they're all your parasympathetic versus sympathetic fibers that are different here. But your pelvic splanchnics are your S2, 3, 4, keeps the penis off the floor, meaning it points or erects the penis off the floor. So pelvic splanchnic, S2, 3, 4, keeps the penis off the floor. Where sacral splanchnics, or S2, 3, 4, shoots the semen on the floor. So that is your sacral splanchnics. S2, 3, 4 shoots the semen on the floor. And remember, if you cannot point, then you cannot shoot. And so the pointing part is very important. So if I damage my pelvic splanchnics, no pointing, no shooting possible, and this person's going to have impotence. And how do I damage those pelvic splanchnics? Either I damage my pelvic splanchnics like peripherally, I cut those nerves for some reason. Person has lower pelvic surgery, or a patient has a spinal cord lesion. So this is someone that might have a sacral cord lesion, where I'm damaging S2, 3, 4 of my sacral or end point of my spinal cord in the sacrum. or really in the lumbar region is where those are going to be found. And so that's very important to remember, is that if this person doesn't have cardiovascular risk and they're not anxious or have psychological problems, but there's some sort of neurological, they were in a car accident or they're paraplegic or something like that, then be thinking that the nervous problem is the cause of their impotence. Now, if we were talking about our artery, back to the cardiovascular risk guy, we're going to be talking about the blood supply that gives this off. Remember our pudendal, greater sciatic foramen out, lesser sciatic foramen in, goes into the deep perineal pouch, supplies all your sphincters and stuff like that. But then, as far as like blood supply, but then it continues as our dorsal artery of the penis and the deep artery of the penis. Those are very important. The dorsal artery of the penis goes right through the corpus cavernosum and fills up this area. So you can see this right here. And this is known as your cavernosal artery. So right here in this picture up on the top. So this fills in all these areas and that causes erection. And what happens as far as what causes that blood supply to go into the penis and the blood supply to stop exiting or squeezing in on those veins are your parasympathetics. And that allows for erection to occur. All right, last few things that we need to discuss are one is your uterus. First, it's normal, and second, it's abnormal. Different location. And so please remember that the normal location of your uterus is anteverted and anteflexed. So anteverted means that we come up and we point in this direction, anteverted. But then there's a flexing point right in the middle that flexes this a little bit further. So it comes up and we antevert and we anteflex. So that is the normal part of the uterus, is like this. Okay? If those are abnormal, something's wrong, okay? So normal, anti. That's super high yield for NBME, BSCE exams, and for your anatomy exams, so please remember anti. It's easy, just 2 A's, okay? Now, if someone has procedentia, also called uterine prolapse, that's a problem. Now, usually we have attachments from the anterior part, the pubo-uterine ligament, we have the sacro-uterine, and then from the sides we have our transverse coming from either side, which is your cardinal ligament. Now, if we have a problem with those, in addition to the muscles that are helping hold up the floor of this pelvis, then this uterus can actually prolapse, meaning it's going to go inside out and down into out of the person. And please Google a picture and you'll never forget it ever again. But the most common cause is cutting of the cardinal ligament. Others are your uteral sacral ligament and levator ani, which is the floor of your pelvis. All right, well, that's it for pelvis and perineum. Thanks for watching. Don't forget to subscribe.